the Myasthenia Gravis Foundation webinar, MG Treatment Guidelines. My name is Kathleen Brown, and here comes my picture. So you can see me now. We're pleased to present our speaker, Donald Sanders, Professor of Medicine at Duke University Medical Center and past chairman of the MGFA Medical Scientific Advisory Board. Dr. Sanders will speak about the development of the MG treatment guidelines effort and the effort to build the treatment guidelines among an international group of MG experts on the use of various treatments for people with MG. The paper is significant, new resource for physicians caring for MG patients. I want to go through a couple of housekeeping points. It's very important that you mute either your phone or your computer. Please don't have both on at the same time because it causes feedback that ruins the sound on the program. To mute your computer, search for volume control and lower the volume completely. Or you can mute your phone and choose the mute button or *6, which works on many phones. And FYI, repeating *6 or #6 will typically unmute a phone. To minimize ambient noise, we will also mute all participants from here. You may ask your questions as you go by typing them in the chat box, which is to the bottom right of your screen. Dr. Sanders will address questions as possible during the presentation. If time allows, we will handle remaining questions at the end of the presentation. Thank you so much for being part of the program. Dr. Sanders, over to you.
Good afternoon, and I'm pleased to be here to talk to you about the recently completed guidance statements on the treatment of myasthenia gravis. As you just heard, these are, I think, very important recommendations or guidance statements for not only patients with myasthenia gravis, but also for physicians and caregivers who deal with patients with myasthenia. These guidance statements were just published in the journal Neurology, and under the sponsorship of the MGFA, they are available for anyone to download from the Neurology website and have access to them. What I'd like to do with this presentation is to go over the steps we followed to develop these guidance statements, and then to go over some of the guidance statements themselves. They're fairly extensive, so I will not be able to go over each one of them in great detail, but I hope that you have had an opportunity to review these statements, or if you haven't already, that you will do so. You can get a copy of the statements directly from the journal by just going to neurology.org, or they can be obtained from the MGFA perhaps more easily for you. In addition to the published guidance statements, which we'll be looking at this afternoon, the entire process through which the guidance statements were developed and extensive background information on these statements are also available online from neurology.org as a compendium document. Well, why do we need guidance statements or guidelines or recommendations for the treatment of myasthenia? Well, as those of you with myasthenia undoubtedly know, there's no generally accepted standard of care throughout the profession of neurology. And myasthenia is a heterogeneous disease. It varies considerably from patient to patient, and the response to various treatments varies among patients with the disease. Thus, there's no one treatment approach that's best for all patients. There's no cookbook that will tell you exactly what to do for every patient with myasthenia. On the other hand, few physicians see enough of this rare disease to be familiar with all of its features, including the potential for improvement or response to various treatments. And there are very few randomized controlled trials, what we refer to as RCTs, of myasthenia treatment. RCTs are considered to be the gold standard for demonstrating that a given treatment works in a specific disease. But on the other hand, even the best RCT could not balance all of the information needed to select the best treatment for each patient. Who else besides caregivers use guidelines? Well, third-party payers do. Your insurance company uses guidelines to determine whether to reimburse for a given treatment. Same can be said for Medicare and Medicaid. Governmental health organizations, such as the NIH, use guidelines to determine priorities for supporting research. And then our institutional review boards, that is the boards at hospitals that oversee research, use guidelines to determine whether or not or how to approve research in specific situations. Recognizing the previous information and the need for recommendations or guidelines in the treatment of myasthenia gravis, the MGFA in October 2013 appointed a task force from its Medical Scientific Advisory Board to develop treatment guidance for myasthenia. And a panel of international experts was convened for this purpose. I and Dr. Gil Wolfe at the University of Buffalo were the co-chairs of this task force, and Dr. Pushpa Narayanaswami at Harvard was the facilitator and moderator of the task force effort. And this task force was sponsored by a grant from the Myasthenia Gravis Foundation. These are the panel members who were asked to participate in the consensus conference and subsequent deliberations on the development of these guidelines. These panel members were selected because of their recognized expertise and experience in treating myasthenia, and all of them have a long history of treating many patients with the disease and publishing extensively on myasthenia over the years. The process that we used is referred to as the RAND UCLA Appropriateness method for developing consensus for treatments of various diseases. This slide outlines this process. We started with a review of the published literature on the treatment of myasthenia, and then synthesized the information in the literature based on existing evidence. From this synthesis, we developed a list of definitions and then recommendation topics. The process proceeds as indicated here on the slide. The panel rates each of the tentative recommendations in at least 2 rounds of discussion and voting. During the first round, there is no interaction among the panel members. That is to say, each panel member sees the tentative recommendation, reviews it, and then votes on it anonymously. The voting process is overseen by the moderator, who is not a voting member. The moderator then puts together the responses to the first round of votes, along with any discussion that accompanied the votes, and then the discussion and votes are synthesized into a second round of interaction that is sent out to the panel members for another vote. This process is proceeded until either the specific recommendation is considered to be appropriate based on the vote, uncertain, or inappropriate. And those recommendations that are then considered to be appropriate based on this process, the discussion and the votes, form the ultimate guidance statement. If there is uncertainty about any statement, or if it's considered to be inappropriate, then that constitutes an area for future research. Among the information that's used by the task force leaders to develop those initial recommendations are any guidelines that have already been published. And it also includes the personal experience of the task force leaders. These are the national guidelines, national or regional guidelines, that the task force leaders referred to and used in developing their initial recommendation. As I mentioned before, each tentative recommendation is initially rated independently by each panel member without discussion or contact with the others, and then is voted on using a 9-point scale. The low end of the scale, a vote of 1, would be considered extremely inappropriate. In other words, that specific for that specific recommendation, the risks greatly exceed benefit. The other end of the scale, what we want to ultimately achieve, would be a recommendation that is considered to be extremely appropriate, which got a vote of a 9, which means that the benefit from that specific treatment recommendation greatly exceeds risks. And the median rating for each of the voting rounds is used as the appropriateness score. The collated ratings are, as I mentioned, after each round presented to the panel for their review and their submission of anonymous discussion. And then each panel member independently and confidentially re-rates each of the recommendations based on the previous discussion. We have agreement among the 14-member voting panel if no more than 4 of the panelists rate the specific recommendation outside the 3-point region, being either low, median, or high, that contains the median. On the other hand, we have disagreement with it if at least 5 of the panelists rate the indication very low and at least 5 panelists rate it very high. So an appropriate recommendation would achieve a panel median score of 7 to 9 without disagreement. An uncertain recommendation would be defined as a median panel score of 4 to 6 or any median score with disagreement. And then an inappropriate recommendation would be a panel median very low, 1 to 3, without disagreement. Our goal was to achieve agreement with a high rating for appropriateness on each of the topics that we included. Before we began voting on the individual topics, though, we defined these 5 terms so that we would have understanding of what we were actually discussing as we go along. What are the goals of myasthenia treatment? What do we mean by remission? How do you define ocular myasthenia? What is myasthenic crisis? And what is refractory myasthenia gravis? I'm going to move forward here to the specific definitions here, if I can find them. Okay, to start with, what are the goals of myasthenia gravis treatment? The conclusion of the panel by consensus was to achieve a task force post-intervention status of minimal manifestations or better with acceptable medication side effects. Now, the term minimal manifestations was defined by a previous MGFA task force back in the year 2000, and it is defined as the patient having no symptoms or functional limitations from myasthenia, which means they have, in essence, no myasthenia, other than some weakness that may be found on examination of some muscles. This class recognizes that some patients who otherwise might meet the definition of remission do in fact have some mild weakness on examination. Acceptable medication side effects are defined by a document called the Common Terminology Criteria for Adverse Events, Grade 1. That means whatever side effects exist are mild, producing very few, if any, symptoms, and not requiring any change in therapy. How do we define ocular myasthenia? This was also defined by the 2000 MGFA task force as their class 1 myasthenia gravis, which means weakness of any ocular muscle, any muscle that controls the eyes, the eye movements, or the eyelids. The only weakness outside of the eye movements themselves would be potentially in the muscles that close the eyes. All other facial, bulbar, that is the muscles of chewing, swallowing, and talking and breathing, and limb muscles would be normal by examination by a physician who was skilled in examining neuromuscular diseases. Well, what is myasthenic crisis? It's very important to have a rigorous and very specific definition of crisis. This was also defined by the 2000 MGFA task force as class 5 myasthenia. This is defined as worsening of myasthenic weakness, which requires ventilatory support, either by intubation or non-invasive ventilation to avoid intubation, except when those measures are used during routine management after surgery. The concept of myasthenic crisis focuses on the clinical implications. It represents a serious, life-threatening, rapid worsening of myasthenia with potential airway compromise from ventilatory insufficiency or bulbar dysfunction. The task force also defined the term impending crisis as rapid clinical worsening of the disease that, in the opinion of the treating physician, could lead to a crisis in the short term. The term refractory myasthenia is used in a number of different situations, specifically in many clinical trials of myasthenic treatments to define a subset of myasthenic patients who are not managed well by any of the currently available treatments and therefore would benefit from a new treatment that is efficacious in myasthenia. So refractory myasthenia is defined as patients whose post-intervention status, and that's the term that was defined again by the 2000 MGFA task force, as being unchanged or worse after taking an acceptable course of steroids and 2 other immunosuppressive agents used in adequate doses for an adequate duration. And that's a critical definition because all too often the immunosuppressive agents that are used in myasthenia are not given in high enough doses or long enough to truly benefit every patient who could benefit from them. And at the end of the treatments that are required under the first bullet point here, the persistent symptoms or side effects that limit, the patient has persistent symptoms or side effects that limit function as defined by the patient themselves and by the physician. After these initial definitions were defined, the guidance statements were developed for these listed 7 specific circumstances. And this is going to be the crux of this presentation. So what I'll ask you to do is to assess the specific recommendations and then ask any questions that you have, bearing in mind that we cannot answer questions related to specific patient treatment. That constitutes the practice of medicine, and we can't do that without actually seeing patients. So feel free to write your questions down here about any of the issues that come up regarding these guidance statements. Symptomatic and immunosuppressive therapy. Number 1, pyridostigmine, that is mestinon, should be part of the initial treatment in most MG patients. In fact, I would say almost all MG patients, with a couple of very specific exceptions. Corticosteroids or other immunosuppressive therapy should be used in all patients with myasthenia who have not met the initial treatment goal. That is, the patient has not achieved the level of improvement that we consider to be our goal in treatment after having received an adequate trial of pyridostigmine. And I would just say parenthetically that not many patients do, in fact, achieve treatment goals over the long term with just pyridostigmine alone. A nonsteroidal immunosuppressive agent, and we'll talk about which these agents are in a minute. Such a nonsteroidal immunosuppressive agent should be used by itself if steroids are contraindicated or patients are unwilling to take them. And a nonsteroidal immunosuppression should be used initially together with steroids when the risk of steroid side effects is high based on patients' specific medical comorbidities. And then if patients are already taking steroids, a nonsteroidal should be added if the side effects of the steroids are considered to be significant by the patient or the treating physician, or if the response to an adequate trial of steroids is inadequate, and then if there's a relapse of symptoms when steroids are tapered. Again, there are many options for selecting among the nonsteroidal immunosuppressive agents that are used for myasthenia. These potential agents include azathioprine, cyclosporin, mycophenolate, methotrexate, and tacrolimus. In selecting among these agents, a number of things should be considered. Number one, there's a widespread variation in practice with respect to choice of an agent, since there's little literature that compares them, and there are no randomized controlled trials that demonstrate which, if any, of these are better than another one in given patients with myasthenia. Expert consensus, tradition, and some random trial evidence supports the use of azathioprine as a first-line immunosuppressive agent in myasthenia. There's also RCT evidence supporting the use of cyclosporin, but the potential for serious adverse effects from this drug and the tendency of this drug to interact with a number of other medications limit its use. In other words, this is a medication that has been demonstrated to work in myasthenia, but the side effects of the medication pretty much overwhelm its value in most patients. And I don't think that there are many patients now in the U.S., at least, being started on cyclosporin for myasthenia. There is no randomized control evidence to support the use of mycophenolate or tacrolimus in myasthenia, but expert opinion and consensus among the panel supports the use of these agents. We then dealt with the two treatments of plasma exchange and intravenous immunoglobulin. These two treatments are considered to be appropriate short-term treatments for myasthenia in the following specific situation. When there's there are life-threatening signs of crisis or impending crisis, such as respiratory insufficiency or difficulty swallowing, in patients who are being prepared for surgery, who have significant weakness of their bulbar muscles. In any other circumstance when a rapid response to treatment is needed, or when other treatments are insufficiently effective. And then in patients who are beginning corticosteroids, if it's deemed necessary to prevent or minimize disease exacerbation. It's been known for many years that patients beginning corticosteroids, myasthenic patients beginning corticosteroids, may actually get worse for a short period of time before the corticosteroids begin to work. And if one treats patients with either plasma exchange or IVIG before beginning steroids, the exacerbations can be minimized or even eliminated altogether. Plasma exchange and IVIG are used more or less in the same way depending upon individual circumstances. The choice between them depends upon individual patient factors. For example, plasma exchange can't be used in patients who have an ongoing infection, and IVIG can't be used in patients with renal failure. And another factor that markedly affects the selection of which of these to use is the availability in the patient's specific treatment environment. they are probably equally effective in reducing the time of necessary ventilation in patients in crisis and in the treatment of severe generalized myasthenia. The efficacy of IVIG is less certain in patients with milder myasthenia or in purely ocular myasthenia. In the very specific circumstance of myasthenia associated with antibodies to MuSK, which is a small percentage of myasthenic patients, plasma exchange may be more effective than IVIG in that specific clinical subset. Although IVIG or plasma exchange is not recommended as chronic maintenance therapy in the majority of myasthenic patients, their use, or specifically the use of IVIG chronically, can be considered for patients with refractory myasthenia or for those in whom all other immunosuppressive agents are relatively contraindicated. We next dealt with the topic of thymectomy, and as you may probably be aware, a prospective randomized controlled trial of thymectomy in myasthenia gravis has just been completed and did in fact demonstrate that thymectomy does improve myasthenia, or at least reduces the requirements for other therapy in patients with myasthenia gravis who have antibodies to the acetylcholine receptor. So our recommendations, or the recommendations of the consensus panel, was that in patients with myasthenia who do not have a thymoma, thymectomy is performed to potentially avoid immunotherapy, or if patients fail to respond to an initial trial of immunotherapy, or who have intolerable side effects from that therapy. The consensus task force worded it as being an option. However, the positive results of the recently completed thymectomy trial would justify a stronger statement, which will be developed to indicate that there is now strong evidence that thymectomy does in fact benefit patients with that particular group of that particular type of myasthenia. Thymectomy is an elective procedure, and it should be performed when the patient is stable and deemed safe to undergo a procedure where postoperative pain and mechanical factors can limit respiratory function. And as I mentioned, these recommendations are consistent with the results of the recent thymectomy trial. The topic of whether or not thymectomy is recommended or beneficial in children with myasthenia was then addressed. And the conclusion of the consensus conference was that the value of thymectomy in prepubertal myasthenic patients is not clear from evidence in the literature, but that thymectomy should be considered in children with generalized myasthenia who have elevated acetylcholine receptor antibodies. Under the bottom two considerations. Number one, if the response to cholinesterase inhibitors, that is mestinon, and immunosuppressive medications is unsatisfactory, or if there's a need or desire to avoid the potential complications of immunosuppressive therapy. And it's recognized that the potential complications of these treatments in myasthenia is more of an issue in children than in adults. Children who do not have antibodies to myasthenia, to the acetylcholine receptor, and who have generalized weakness, it may be difficult to distinguish between autoimmune myasthenia and one of the several forms of congenital myasthenia. The congenital myasthenic syndrome patients do not improve with immunotherapy or thymectomy. To be sure of which of these forms of childhood myasthenia we're dealing with, it's recommended that before a child is considered for thymectomy, that it would be of advantage, it would be of benefit to the patient to be evaluated at a center specializing in neuromuscular disease. Thymomas, tumors of the thymus gland, occur in somewhere between 15 and 20% of patients with autoimmune myasthenia gravis. These are usually benign tumors, but with rare exception, they should be removed surgically in virtually all patients. And when the surgery is being done, all identifiable thymus tissue should be removed along with the tumor. If the tumor has extended beyond the boundaries of the thymus or meets the definition for malignancy, then other treatments for the tumor are indicated. And as Colleen just asked, what's the protocol for follow-up treatment of patients with thymoma? It really depends upon the histology of the tumor, of the tissue that's removed. If it's benign and does not extend beyond the thymus itself, then the prognosis is very good, and there's very little likelihood of return. And whether or not one needs to do follow-up imaging studies such as repeat CT scan depends upon that. It should be kept in mind that unlike thymectomy to remove an enlarged but non-thymomatous tumor, removal of the thymoma itself doesn't usually or frequently produce improvement of the myasthenia. The surgery is done primarily to remove the tumor, not to improve the myasthenia. If the tumor can't be removed entirely, then there should be an interdisciplinary treatment approach with radiation therapy or chemotherapy determined by the oncology specialist. Elderly patients or patients who have more or many or complicating illnesses may be treated for the thymoma with radiation therapy as an alternative to surgery. In such patients, small thymomas in some circumstances may be followed without treatment unless they are enlarging or becoming symptomatic, in which case they can be dealt with surgically. We talked about the various ways in which the thymus can be removed. A number of minimally invasive surgical techniques are being used, and more, I'm sure, will be developed in the future to perform thymectomy. And these generally have a good track record for safety inexperienced centers. But there are no comparison studies to show whether or not these minimally invasive procedures are in fact as good as the, I won't say old-fashioned, but the open approach, open surgical approach that was used up until a number of years ago. The panel then addressed the question of whether thymectomy is of value in patients who do not have antibodies to acetylcholine receptor. There is insufficient evidence in the literature to make a recommendation for surgery in such patients. However, thymectomy may be considered in such patients if they don't respond adequately to immunotherapy, or if it's desired to avoid or minimize the side effects of such immunosuppressive therapy. And as I indicated earlier, the current evidence does not support an indication for thymectomy in patients with MuSK antibodies or any of the other new antibodies that are being discovered, such as the LRP4 or the agrin antibodies. We really do not have enough information to make a strong recommendation for or against thymectomy in these patients. Very much up to the judgment and experience of the individual treating physician as to whether this should or should not be considered. Well, what is the recommendation for the treatment of myasthenic crisis? Either the impending crisis or crisis that is fully developed. Well, plasma exchange and IVIG are the mainstay of management of patients in crisis or impending crisis. All patients with crisis should be admitted to an intensive care unit or a step-down unit where they can be managed and monitored for respiratory failure and bulbar dysfunction. If the crisis is not fully developed, then the patient certainly should be admitted to the hospital and observed closely for the potential development of such respiratory or bulbar dysfunction, with the ability to transfer the patient to an intensive care unit if the clinical scenario changes to manifest crisis. As mentioned earlier, plasma exchange and IVIG are used as short-term treatment for the patients in impending or manifest crisis, and also in patients with significant respiratory and or bulbar dysfunction. Corticosteroids and other immunosuppressive agents are often started at the same time to maintain the improvement that is initially induced over the short term by plasma exchange or IVIG. Although some clinical trials suggest that these two treatments are equally effective in the treatment of crisis, expert consensus among the panel suggested that plasma exchange is more effective in crisis and works more quickly. The choice between the therapies depends upon patient comorbidity, as mentioned earlier, and other factors including availability, again, as mentioned earlier. We next address the subset of myasthenic patients who have antibodies to muscle-specific kinase. This is a group of patients that have been recognized over the last, I think it's now about 15 years, because they, number one, have the antibodies to the MuSK and not antibodies to the acetylcholine receptor, and also because they have a number of clinical features that differ significantly from the other patients with myasthenia. One of these differences is that many of these MuSK myasthenic patients respond poorly to cholinesterase inhibitors. They either don't get better, or in some patients, these medicines actually make their myasthenia worse. And it can do that at doses that are very small. On the other hand, patients with MuSK antibodies appear to respond quite well to corticosteroids and to many of the previously mentioned immunosuppressive steroid-sparing agents. These patients also respond quite well to plasma exchange, while their response to IVIG seems to be less effective. And the medication rituximab, which is a monoclonal antibody, immunosuppressive monoclonal antibody, seems to be extraordinarily beneficial in many MuSK patients and should be considered as an early therapeutic option if these patients have had an unsatisfactory response to their initial immunotherapy. Let me just take a look through some of the questions that the folks have asked here to see if any would be appropriately addressed before we move on to treatment of myasthenia in pregnancy. Here's a question from Bruce, who wants to know if there are any plans on developing emergency treatment protocols for MG crisis or EMS and emergency rooms. Well, it's the same protocol that you would use for any patient who can't breathe. You'd make sure that they've got an airway and get them to the closest emergency room. In the emergency room, they should know how to deal with respiratory insufficiency of any cause. And the main essential treatment for myasthenic crisis is to make sure the patient can breathe. And then once the ventilation has been managed, then the specific treatment for the patient can be undertaken. Melissa wants to know whether the recommendation for thymectomy in pediatric patients with ocular myasthenia and no thymoma is different than it is for adults. I'm not sure whether we actually have a slide on this or not, but because ocular myasthenia in children has a very high frequency of spontaneous improvement, we would not recommend thymectomy until or unless there had been adequate time to be sure that the patient wasn't going to get better on their own without any specific treatment, or that the patient was not going to progress to generalized myasthenia. That's a very good question, and one that requires knowledge of the predicted course in these patients. Let's move on now to treating myasthenia Oh, here's a question. Okay, Lynn wants to know, in the ER or on a 911 call, the patient can't talk. How does the responder know you have myasthenia? Well, you ought to have a bracelet that says you have myasthenia. And how do you deal with that on a 911 call? That's a very good question for which I don't have any very specific answer. But I think a patient with myasthenia ought to have a provision for someone to be around if they're at risk for this particular scenario. Richard wants to know what experience should cardiac surgeon have before doing your thymoma, doing your thymectomy. A lot. That's what I would say. I'd want to find out how many thymectomies he or she had performed and what their outcomes had been. I think that's a critical element in selecting a surgeon for a thymectomy. Is it proper, Colleen wants to know if it's proper protocol for all MG patients to be tested for MuSK before undergoing treatment. It's very rare for myasthenic patients to have both MuSK and receptor antibodies. So if the receptor antibodies are positive, then there's no need in most cases to also test for MuSK. It's only in the patients who don't have acetylcholine receptor antibodies that we generally test for MuSK antibodies. Okay, let's move forward now and talk a bit about MG and pregnancy. This was a topic that took a lot of discussion because there are a lot of issues that come up regarding pregnancy and myasthenia. And one of the things that I think we do emphasize is that myasthenia is not a contraindication to becoming pregnant. However, planning for pregnancy should be instituted well in advance to allow time for optimization of the myasthenic clinical status and thus to minimize risk to the fetus. Spontaneous vaginal delivery should be the objective and is actively encouraged. It's very important that relevant specialists become involved throughout the pregnancy, delivery, and in the postpartum period. That means you're treating usually neurologist and a OBGYN who's skilled in dealing with complicated surgeries. The majority of women can be assured that they will remain stable throughout the pregnancy. If they do get worse, this is more likely to occur during the first few months after delivery and not during the pregnancy itself. Doesn't mean they can't get worse during the pregnancy, but you can't stop monitoring or observing for worsening just after delivery. The patient has to be monitored for several weeks, maybe even a couple of months after delivery, because that's a time in which worsening can occur. Pyridostigmine is, again, the first-line treatment during pregnancy, but intravenous cholinesterase inhibitors should not be used during pregnancy because they cause uterine contractions. The immunosuppressive agent of choice during pregnancy is prednisone. Despite the side effects, it's much better than the other alternatives. On the other hand, current information indicates that azathioprine and cyclosporin are relatively safe in expectant mothers who are not satisfactorily controlled or who cannot tolerate corticosteroids. This statement achieved consensus, but there was a strong minority opinion against the use of azathioprine in pregnancy, which is of concern mainly in the United States. Outside the U.S., azathioprine is felt to be safe for use during pregnancy. On the other hand, mycophenolate mofetil and methotrexate both have an increased risk of fetal malformations and are contraindicated during pregnancy. And if a patient who's taking either of these medications is planning to become pregnant, they need to make alternative treatment plans well before they do become pregnant. Both plasma exchange and IVIG are useful as a short-term temporary improvement if required during pregnancy, but the maternal and fetal risks must be weighed in advance against the potential benefit. Thymectomy doesn't need to be done until after pregnancy is over. It's not an emergency procedure, it's elective, and any benefit from thymectomy is unlikely to occur during the pregnancy itself. So any plans for thymectomy should be postponed until after pregnancy. An issue that arises all too often is the use of magnesium sulfate in myasthenic patients. This is a specific treatment for the management of eclampsia, but in myasthenia can be dangerous or is usually dangerous. And eclampsia can usually be managed otherwise in myasthenic pregnant patients. Chest CT without contrast can be performed safely during pregnancy, although as with any radiologic procedure, the risks of radiation to the fetus need to be carefully considered, and any diagnostic radiographic procedure, including CT, should be postponed until after delivery, if that's reasonable to do. Somebody raised a question earlier about the risk of contrast agents, CT contrast agents, in myasthenia. There was a paper 2 years ago that reviewed the risk of currently used contrast agents and concluded that this risk was much less, if not negligible, than the previous contrast agent, the old contrast agents that were well recognized as causing problems. So I think the consensus now is that the use of contrast agents with CT scan in myasthenics is not the risk that it used to be considered. One thing that is very important to keep in mind during pregnancy and myasthenia is that the children born to myasthenic mothers may develop a temporary form of myasthenia and should be monitored carefully for this, even if their mother's myasthenia is well controlled. And these infants should not only be monitored, but have rapid access to the necessary, potentially necessary critical care support that may arise. Well, here we are with the question about ocular myasthenia in children. As I mentioned, these children are more likely than adults to go into spontaneous remission, and thus children with only ocular symptoms can be treated initially and for a long period of time with pyridostigmine. Immunotherapy can be considered if the goals of therapy are not met with pyridostigmine alone. An issue that involved considerable discussion was whether maintenance chronic plasma exchange or IV should be used as alternatives to immunosuppressive drugs in children. with myasthenia. And the overall conclusion is that it is much more reasonable to consider that in children than it is in older myasthenic patients. One issue is the greater risk of chronic side effects of immunotherapy in children, and the fact that, again, many children do go into spontaneous remission, and that would not require lifelong therapy with these agents. Okay, these, again, are the 7 final recommendations that comprise the guidance statements for the treatment of myasthenia. I hope that you have found this presentation informative about what's included in these recommendations, and now know what information you can use, you can impart to your treating physicians if they don't already have a copy of this, and that you can use for your own planning for dealing with your disease. Are there any final questions appropriate to this presentation that I can deal with before we leave? Bruce, I'm afraid I can't answer your question because I'm not fully apprised of the EMS-ER packet. I do know that there is some discussion about updating an EMS package, so hopefully that'll deal with your question.
Hello, everyone. This is Kathy Brown. I don't want to cut us off, but I'm just jumping in because we will wind up. Is there anything else that anybody would like Don to try and help them with? And I do want to react to Bruce Yelverton's comments about being a former EMS director. I will get in touch with you after this call because we are looking for readers of the material. So I believe we should have your email, and I will get in touch with you. So I just see somebody is typing right now. Okay, I see thank yous. And let me just say thank you also to Dr. Don Sanders for taking the time to do this. We appreciate your time, your expertise, your help with this, and for actually coordinating this, this whole project, which I believe will have a significant positive impact on the arena. And I want to thank everybody who's shared with us on the phone here, and stay tuned for future MGFA webinars. Thank you, everyone.
Okay, if I could just make one final comment, and that is to reiterate the major role that the MGFA played in bringing about these guidelines, getting them published, getting them disseminated, and now sponsoring this webinar. Thank you very much for that.
All right, everybody, take care.